Welcome, everybody. My name is Jason Goldman, and I'll be sitting in for Jim Heath tonight. He couldn't make it today, and we'll be doing our Recover Pacific Northwest Town Hall tonight. Thank you, everyone, for joining. We have a big group of registered Town Hall participants tonight, so thank you, everyone, for your interest. Here is the agenda that we're going to go over tonight. Let's see if I can advance here. There we go. First we'll do a welcome. We have some great speakers today and a pretty packed agenda. We'll try to do the content agenda in about 30 minutes today, and then do a question and answer for the second half. A couple housekeeping items. Please feel free to submit questions via the Q&A box in the Zoom meeting format. You can do this anonymously by checking that box. We will go through your questions and also some of the questions submitted in advance. There's quite a lot of questions, so thanks everyone for your interest and engagement here, and we'll try to get through as many of the questions as we can. We have some great talks today. I'm going to talk a little bit about Recover 2.0 and what are the next steps for the study. It is being extended. Julie Wallick and Katherine Tuttle will talk about biological sex and long COVID. And then I'll give a brief presentation on what we're learning about autoimmune diseases after SARS-CoV-2 infections. And then Ethan Pascual and Lea Dahlke from Cedars-Sinai will give some reflections on participation, engagement, and Recover. And we'll then go into the Q&A after that. So without further ado, let's launch right into it. So as I mentioned, Recover has given the go-ahead for what we're calling Recover 2.0. This is a extension of the study that we've been participating in and you've all been participating in. The idea here is to try to find longer-term follow-up. And this is a little bit of a pared down study. It won't be quite as intensive on the study visits or the exams that are being done. But the basic premise of this extension, Recover 2.0, is to address the following three aims. One is to define the long-term trajectories, and specifically for some long COVID phenotypes like neurocognitive dysfunction, cardiopulmonary, and infection-associated chronic conditions like ME/CFS, fatigue syndromes, and autonomic dysfunction. Aim 2 will be to investigate the biological drivers and candidates for epidemiological factors. So thinking about how inflammation, immune responses, or viral persistence might impact what people are experiencing who are living with long COVID. And aim 3 will look at links to the onset of chronic conditions. Some of them that have been mentioned, like neurodegenerative disease, cardiometabolic, and autoimmune diseases. We'll talk a little bit about what we've learned about autoimmune diseases tonight. So here's the study design. This is a little bit of a complicated slide, but let me just kind of break it down as that the people who are participating in Recover are going to be sampled for who's invited to participate in Recover 2.0. The study design is what's called a case cohort study, which means that cases of long COVID are selected, and then some cases who are not long COVID are selected. The continuation is going to try to enrich for people who are experiencing long COVID, meaning since that's the disease under study, we enrolled a lot of people when they first had SARS-CoV-2 infection. We didn't know if they're going to develop long COVID or not. The Recover 2.0, we really do want to focus on following up the people with long COVID. So this is a schema in this slide of how that's going to happen. The big circle represents a random selection of people who will be included. That will include patients who have long COVID and patients who don't have long COVID, like those empty circles. And then in the second step of the selection, patients with long COVID meeting a certain research definition will get included to enrich the case group for more people who have long COVID. And this idea was developed by a big panel of scientists at Recover to try to make it flexible and scientifically rigorous, but also flexible and cost efficient. So here is what's going to happen in terms of the case selection with the case definition. So what that means is people with long COVID, for the purposes of the study, are going to be selected using this long COVID research index, and that is a set of symptoms that combine to create a score and define who's very highly symptomatic with long COVID. So you can see a whole listing of symptoms here. These are common symptoms that were reported in the National Academies of Science, Engineering, and Medicine definition for long COVID, which is that sort of first green column there. And then the Long COVID Research Index, or LCRI, was developed within Recover 1.0. And it has many of these same symptoms, and it's a data-driven exploration of all the symptoms reported by all of you and everyone else across the country, and symptoms with higher points are given if patients have a higher chance of having those after COVID versus not after COVID. So you can see how the points breakdowns go for the Long COVID Research Index. Patients with a score of 11 or higher are selected as cases. It doesn't mean that people with a score of 11 or lower do not have long COVID. They might, but we feel fairly confident that people with a score of 11 or more do have highly symptomatic long COVID. So this is the sort of scheme of how people will be selected for the transition to the Recover 2.0. And this is a little bit more on the study design. We're thinking about nationwide trying to continue participation for over 5,000 participants, close to 3,000 of whom are patients with long COVID, and just over 2,000 are patients who might or might not have long COVID but don't meet that case definition with the Long COVID Research Index. And not all patients are going to have symptoms in all of the domains. These are just sort of projected estimates, but we'd anticipate that around 50% of the people meeting the case definition for long COVID will have neurocognitive symptoms. 75% will have cardiopulmonary symptoms, and 91% will have an infection-associated chronic condition or the associated symptoms. And you can see the breakdown of those symptoms and what our baseline data from Recover has shown so far in terms of what percentage of the patients in Recover already have these symptoms. So that's a brief introduction to the extension phase of Recover 2.0, and we can certainly address more questions about that in the Q&A in the second half of tonight's presentation. We'll hear next from a really exciting manuscript on biological sex and long COVID that was analyzed from the Recover data. And Julie Wallick and Kathy Tuttle will both be speaking about this topic. So I'm going to stop sharing and let Julie share first.
My name is Julie Wallick. I'm a research manager at Providence Swedish. And I am going to talk about the paper looking at sex differences in long COVID. So the question that we asked when looking at the data was, does sex assigned at birth impact the risk of developing long COVID? There have been prior studies where it has been shown that there does seem to be some sex-linked risk factor for developing long COVID, and it's been seen in other post-viral illnesses. Why are we asking this question again? Well, Recover, due to its size and the systematic way that we collect information, including things like vaccine status, comorbidities, um, infection status, help give a much more robust picture and answer this question. So who was included? So we were looking only at the adult Recover study participants. There was 12,276 participants who were included in this analysis. So pretty big. And it's broken down here a couple different ways. So sex assigned at birth, we can see that 8,969 were female and 3,307 were male. This breakdown is a little bit a symptom of who participates in this study. And then COVID infection status. So this is another unique thing that Recover has allowed us to look at. So you can see here that we included 7,691 patients who had a COVID infection greater than 30 days prior to enrollment. 3,814 had their infection within 30 days of enrollment. So we think of that as our acute group. And 771 patients had their first COVID infection after they enrolled into the Recover study. What did we look at? So part of participating in the Recover study, participants are asked to complete questionnaires around their symptoms every 3 months. And long COVID was marked as positive based on the presence and severity of symptoms at least 6 months after their COVID infection. These probably look familiar, but some of these symptoms that we looked for to note someone as positive included post-exertional malaise, fatigue, brain fog, dizziness, palpitations, loss or change in smell and taste, thirst, chronic cough, chest pain, shortness of breath, snoring, or sleep apnea. So ultimately, what did we find? We did find that overall females have a 1.31 times higher risk of developing long COVID versus males. We saw that the group at highest risk for developing long COVID were females aged 40 to 54. I think very interestingly, and I think Dr. Tuttle is going to be able to expand a little bit more on this, but this higher risk changes when we look at the population sliced a few different ways. So pregnancy during or after infection reduced the risk of developing long COVID. So some protective factors with pregnancy. The risk for developing long COVID also changes based on menopausal status, and then age, which we see here in this highest risk group between 40 and 54. That age group was at a higher risk when we look at females younger than 40. We saw less risk, maybe due to more pregnancy in that age group. And then females older than 54, we did not see an increased risk based when compared to males. So what's next? The study adds to our understanding about how sex at birth affects the risk of developing long COVID, but it doesn't answer everything. More research is needed to understand why there's these differences in sex at birth put some people at a higher risk of experiencing the long-term effects of COVID, and then understanding if and which sex hormones play a role in long COVID risk could help researchers in developing treatments and or ways to prevent long COVID. And I am going to let Dr. Tuttle give her physician perspective on this paper.
Well, thank you, Julie, for that overview. I think it was really fabulous and very interesting. And, I think when we consider sex differences, oftentimes the interest is in sex hormones. For example, we see a lower risk in women who are pregnant. And in some ways, that is consistent with what we've known about pregnancy for a long time, is that there is, if you will, an immunosuppressive effect of pregnancy. In pregnant women, we see autoimmune diseases often go into remission and then flare post-pregnancy. So to me, it's kind of interesting just in terms of context to see that there was a lower risk of long COVID among women who are pregnant. And that may be some protection from autoimmunity by sex hormones that are increased during pregnancy. But it's not all about sex hormones either, because as you pointed out, in the women who were 50 to 54 years old, some were premenopausal and some were postmenopausal, but that didn't affect the risk of developing long COVID. And in a methodologic analysis, something called a sensitivity analysis, where they controlled for what we call comorbidities. So other conditions that women during that age group had, for example, obesity, asthma, presence of autoimmune conditions, then female sex was no longer associated with a higher risk of long COVID. And the fact that it was no different by menopausal status suggests that in that age group, the risk may not be driven by sex hormones as much as it is by the fact that women in that age group are starting to develop chronic conditions that predispose to COVID. And after age 55 and older, there was no sex difference, suggesting that as men and women start developing more chronic conditions that predispose them to long COVID, like cardiovascular disease, like chronic kidney disease, like diabetes, that probably drives the risk in older groups. So there's a lot more to the story, but it's important because it helps us understand who's at risk. It helps us identify people that we want to pay close attention to in terms of any potential interventions, and also what interventions might work. So, for example, in the younger age group, they may be different than in the older age group, depending on what's driving the risk of long COVID. So those are just some perspectives for context and some inferential viewpoints about the paper. So it's really just a first paper, and we certainly have a lot more to learn, but this takes us further down the line of being able to develop better diagnostic strategies and also potential therapies that might help people based on their personal characteristics, whether they be age or sex or other chronic common conditions that seem to predispose to COVID.
All right. Well, let me share my slides again. All right, so I'll talk next briefly about long COVID and autoimmune diseases. We recently, last month, published a paper from the Recover EHR cohorts, and I'll tell you about that. So first of all, a little bit of background. Autoimmune diseases is now pretty much considered a feature of long COVID. What autoimmune diseases are when the body's own immune system attacks the body. And this can result in inflammation and many different types of diseases. There have been a number of studies now showing that this association is there, meaning that in these big databases of large numbers of health records, from various different countries, including the United Kingdom, Hong Kong, Taiwan, and South Korea, they've all shown an increased risk for autoimmune diseases after SARS-CoV-2 infection compared to various control groups. And here are some of the types of autoimmune diseases that these other studies have shown: type 1 diabetes, inflammatory bowel diseases, psoriasis, rheumatoid arthritis, Graves' disease, or just some of the more common autoimmune diseases that can occur after long COVID, and there are many others as well. In Recover, we amalgamated many patient medical records in these 3 different cohorts. Now, my medical center at Swedish isn't participating in these groups of assembled medical records, but we did have an opportunity to participate in this analysis through the Recover. N3C, Picornet, and PedsNet are 3 different sort of amalgamated data sets. And the first 2 deal with adults, and the last one with children. These are really huge data sets. So in NC3, there were more than 1 million patient records. In Picornet, there were about 600,000. And in PedsNet, there was about 160,000 children included, the medical records for them included. And what this study added was it assessed how autoimmune diseases develop based on how severe the SARS-CoV-2 infection was at the time of the acute infection. And in these cohorts, we followed included patients for 2 years to assess for new onset autoimmune diseases, and those were based on having 2 diagnoses in the clinic. So here are the main results for adults. These are survival curves. So people who have, no, let's see here. The scale here is from 1 to, this middle one is 98 or the bottom's around 97. So those are people without the condition. So, at the end of this, in the yellow group, people who are outpatients when they first had SARS-CoV-2 infection, just, a little over 1% developed autoimmune diseases. But as you can see, as you go down the colors, people who are hospitalized on a ventilator is orange, is that bottom color. They had the higher risk of developing, an autoimmune disease. And they had a nearly 3% risk in this cohort, which was NC3, and in Picornet, similar distribution of seeing a higher risk as we get to more severe disease. But this cohort had a little bit less detection of autoimmune disease for whatever reasons. And here in PedsNet for the children, they used a little bit of a different definition of severity, not based on where a patient was treated. Like in the adults, used outpatient versus inpatient versus critically ill. Here there was a different definition based on asymptomatic, mild, moderate, or severe, and a very similar type of result. Approximately 3% of the sickest children with SARS-CoV-2 developed the autoimmune disease, whereas people who had asymptomatic or mild initial SARS-CoV-2 infection, much less than 1%. So I think this adds to our understanding of autoimmune disease, in that we do find clear associations in these large medical records cohort studies with increasing autoimmune diseases as there's more initial SARS-CoV-2 severity. So we think of autoimmune diseases really as components of a long COVID syndrome, and they're diagnoses, not symptoms. And we can talk more about that in the Q&A. So with that, I will stop, and we will let go to the next part and talk about patient reflection. So Lea and Ethan, if you guys could share your slides. Thank you.
I'll just briefly introduce myself. I'm one of the study coordinators at Cedars-Sinai. So I've had the pleasure working with long COVID and recover studies for the past 3 years, starting with the recover observational study along with vital and auto trials. For today, we really wanted to kind of highlight the reflections that we've had from participant engagement the with these studies. And one of the things we wanted to highlight was the fact that through our work with listening to participant stories and really this kind of journey of following up with participants, whether it's on an auto trial for 12 months or the observational where it's been about 2 to 3 years, we've really seen through patient stories that it's not a one-sided thing of the experts as the researchers, but also the experts are the participants, and really kind of highlighting their own stories and experiences with long COVID that has allowed us to become better clinical researchers or study coordinators and for PIs of kind of putting together these narratives and experiences. Slide, please. So we have this cartoon to kind of highlight that, which kind of captures it perfectly of it's a conversation between experts, and the experts are the participants and also our PI and study team. And then slide. And I think I kind of touched on this earlier, but through working with our study participants, we've really seen as well a lot of the symptoms that have been highlighted through the research we've heard in a narrative style as well. We're kind of connecting a lot of different symptoms regarding like post-exertional malaise or brain fog, and really this this story of kind of having long COVID and this before and after experience. But we also wanted to highlight kind of the individuality that exists with a lot of these long COVID symptoms and experiences being very distinct as well. And this has allowed us, and I'm sure other people speaking today can kind of agree from working with research participants and kind of learning more about long COVID, has a participant engagement has been huge to this kind of work. And I think the last point that we were going to highlight, I think Susan wrote this, and it's really a testament as well to her experience in working with clinical research for the past 25 years of having one thing she always shares is working with long COVID patients. She's really seen how informed study participants are. And with the research, a lot of patients will share with us the latest research or studies that are happening and specialists. So we just kind of wanted to give a shout out because we recognize that these studies, takes time for research, and we really appreciate everyone's participation and ongoing efforts.
Hi, everyone. My name is Ethan. I'm one of the research coordinators at Cedars-Sinai. I am also a PhD candidate who's focusing on my dissertation on individuals who have long COVID, and I want to see the impacts of resistant exercise and how it affects their pulmonary function and muscular strength. So I actually possess a strong connection with the long COVID studies, and so it's a true privilege to be here speaking with you all. But over the Recover initiatives, regardless of how robust methods are and how thorough protocols are, we have realized there have been treatment challenges that we've witnessed through these studies. Some of which, first off, we don't know the true mechanisms of long COVID. What we do know is that it's a systemic disease that affects various organ systems, and so through these clinical trials, we're learning piece by piece and gaining a better understanding that there most likely isn't a one cure fits all approach to long COVID. And so initiatives that are such as these Recover initiatives are very helpful in, finding that treatment. And then finally, unfortunately, recently there's been a lack of advocacy and support from policymakers and the public regarding long COVID. But through ongoing initiatives and better understanding how the patients are going through with what they're diagnosed with, we can better understand the diagnosis of long COVID and come up with better treatments. And so, I'm sorry, my slides are messed up, but overall impressions. Over time, our study has developed strong connections with many of the participants, and surprisingly, for many of them, we are that last resort in helping them find some sort of recovery in their treatment. And so, while our team is well versed in the study protocols and clinical procedures, we this is a mutual connection between study teams and the participants in our studies to find these solutions to treating long COVID. So thank you.
Thank you so much, Lea and Ethan, for those reflections on patient engagement and participation. We're going to next take the rest of the time, the second half of this hour, to address your questions. And Kathy Tuttle is going to moderate this section. We've received a lot of your questions in advance. There was actually pages of them, so thank you all for your engagement. And we will try to get to as many as possible. I think Kathy's going to try to group some of them together. We've also seen your questions, live in the Q&A, we'll do this. Try to do this conversationally. So thanks so much, Kathy, for moderating, and you can take it from here.
All right. Thank you, Jason. Yes, it is interesting to see all your questions, and there's some big common themes, and I'll try to summarize them for our panelists and give them a chance to give their reflections. Jason, one of the questions that came in during your presentation was a question about immune deficiency disorders. So, you talked about autoimmunity. There's a question about the potential association with immune deficiency syndromes. Do you have any thoughts on that topic as well?
Yeah, that's a great question. So thank you for addressing that. This is a complex question, actually, and autoimmune diseases can cause some types of immune deficiency syndromes, and what this means is immune deficiency is a weakened immune system. So there are certain conditions where either the disease itself or the treatments used for autoimmune conditions can cause a weakened immune system. Um, People who have weakened immune systems we know are more susceptible to severe COVID, and they're more susceptible to persistent infections. I saw also a lot of questions about persistent infections, so I'm sure we'll get to that at some point. Um, so whether or not autoimmune disease and immunodeficiencies are directly related in long COVID, I'm not certain about that. We usually sort of study them separately, but there has been a sort of a wealth of information about acute COVID and how people with weakened immune systems are at much higher risk. I don't know how that relates to some of the common symptoms that we see in long COVID. But what I do think we know is that people have more severe disease, which can, be itself associated with more and worse long COVID. And people have persistent infections, which also can be associated with long COVID. So I think there's a lot of, good theory there about how weakened immune systems might play in with the long COVID syndrome in general, but a very complex area clinically and hasn't been really well studied from data that I've seen.
So I'm going to pivot to some of the questions that were submitted ahead of time. We'll just kind of toggle back and forth, so we try to cover most of them. So I think building on that theme, there was a question about biomarkers for development, severity, and duration of long COVID. And I guess I would also think about phenotypes. You opened with saying the new study is going to focus on neurocognitive, cardiopulmonary, and then the fibromyalgia, autonomic neuropathy syndromes. Any of you can weigh in here about developments that not only might help untangle the knot of what is long COVID, but anything that might help us identify those phenotypes up front and what people are likely to experience with long COVID.
Yeah, maybe I'll just open up a little bit because this is also a complex topic, and I did see a lot of different questions relating to this. Maybe I'll, Lea and Ethan, if you guys can describe some of the ways that people fit into inclusion in some of the trials, that is also kind of a way of thinking about what long COVID phenotypes are. At Cedars-Sinai, I think you guys enrolled on Recover Vital and also on Recover Autonomic, if I'm not mistaken. So, the people who fit the inclusion criteria for those studies have a certain phenotype, and some of the Recover clinical trials have done a really good job of getting very detailed phenotyping of people to be included in these trials. And the reason we do that is because long COVID is so complex and so multi-armed. There's so many different flavors and types of long COVID that if we can kind of hone down onto one type of phenotype, like neurocognitive or, like fatigue, post-exertional malaise, those types of phenotypes might respond better to certain treatments than kind of lumping everyone together into one big box. So Lea or Ethan, maybe you can describe some of the phenotypes there.
Absolutely. For the Recover Autonomic study, we've actually been primarily getting individuals who have autonomic dysfunction. And so, the active stand test is the thing that will either exclude them or include them right off the bat. But, I've worked on other long COVID studies that primarily focused on pulmonary disorders, and they don't have a abnormal active stand test or any sort of autonomic dysfunction. So it's pretty fascinating. And some of the literature currently, they say there's over 200 symptoms of long COVID. And so it just goes to show that these phenotypes, we may find the cure to one, but there's still 190 more to do. And so it's quite fascinating. Lea?
Yeah, and just to add on one of kind of what Dr. Goldman was speaking on about kind of the classification, we saw that in the VITAL trial where we kind of had a cognitive cluster and then a exercise intolerance and a autonomic kind of dysfunction. So we have seen these different this separation of clusters, which I think was helpful for study participants, as some may have a combination, some qualified for multiple clusters and some qualified for just one. And we had different assessments of we'll do questionnaires regarding kind of POTS-like symptoms for the auto trial. These studies are really trying to capture, especially with the questionnaires we have for not just eligibility, but seeing it through follow-up and end of intervention to kind of capture these symptoms.
Right. And the question you asked, Kathy, was really about kind of biomarkers. So, we don't have specific lab tests that classify people into the different types of phenotypes. But, filling out a questionnaire about your symptoms is a type of biomarker. It's not a, biologic or laboratory biomarker, but it is a biomarker, and that can be followed over time. So doing a questionnaire at the beginning that shows, you have a lot of dizziness when you stand up or a high heart rate when you stand up on an active test. Those are two different types of biomarkers that we can follow over time in a study. So I do think that some of the long COVID syndromes do have some, real true biomarkers as we think of them. Like, for instance, restrictive lung disease is something that Dr. Chen studies a lot at Cedars-Sinai. We can measure that with pulmonary function tests. So that's a classical biomarker, whereas some of the other ways we're phenotyping the different long COVID syndromes is, by these questionnaires. And there is a lot of active development which will continue in Recover 2.0 on true biologic biomarkers. Maybe, Kathy, if it's okay, I'll just talk a little bit about viral persistence, because I know I saw a couple of those questions in the Q&A. I think viral persistence is one of the most interesting and kind of vexing phenotypes that we're seeing. Especially to me as an infectious disease doctor, this is the sort of, I think of it as the central part of long COVID. Maybe viral persistence, generates the chronic inflammation that we're seeing in lots of different biological studies, including some that we've done in our group here. There have been there's been two different studies that looked at persistent SARS-CoV-2 spike antigen and other antigens. And, in a big cohort that included some Recover study samples and some samples from other cohorts, there was about a 25% persistence at 14 months of spike antigen. We presented this at the last town hall. So I think of this as a very important, true biomarker but all those other, 3/4 of the people, had the symptoms of long COVID, but didn't have the persistent biomarker. So that, that could be for various reasons. It could be that our test isn't good enough, or it can be that there really are truly different types of long COVID, and some people do not have persistence of the virus or the persistence of the proteins from the virus. So I think this is still a really active area of development.
Thank you. And Julie, let's shift over to you and some questions about our paper on sex differences. And there's a question here about differentiating onset of perimenopausal symptoms with development of long COVID. Can you provide your thoughts about that question?
Yeah, I think it's a really good question and hard to parse out in the way we collected data. I think the questionnaires phrase the symptom survey as related to long COVID. So I think if someone didn't know their symptoms were related to perimenopause, they may attribute them to long COVID. So I think, I don't think we have a good way to say whether or not we can distinguish other than patients self-report on whether their symptoms were related to long COVID from their perspective.
Thank you. And there was another question that maybe I'll address is when we talk about the sort of research, this observational research, can we infer causality or just correlation? And really, it's just correlation. These are hypothesis, what we call hypothesis generating data. We can say, for example, these symptoms are associated with long COVID and perimenopause, but that's where the hypothesis actually has to be tested in a longitudinal and interventional type of trial. So I want to be clear that this is sort of, the beginning, even though, we're 5 years into COVID, is unraveling this knot, as you've heard about in multiple dimensions. But these give us directions to point and tests that we can do to try to sort out how much is causation versus correlation. Let's see. Do repeat COVID infections cause worsening symptoms for long COVID sufferers? I'll just open that to the group, whoever wants to take that one.
Yeah, I can start. That's a great question. There has been some observational research and not part of Recover, but has addressed this question. There's a really nice paper from the Veterans Health System that addressed this topic. And what it found was repeat infections still can be associated with the development of long COVID. And it seems like the incidence of long COVID, or how many new long COVID disease states arise, sort of declines for reinfections compared to primary infections. So I think overall this is good news in that having a prior infection protects you a little bit, but it doesn't make it impossible to get long COVID, unfortunately. And I think of this a little bit in terms of the immunity that we develop from a prior infection, and we can also develop immunity from vaccines. So, lots of studies now have shown that vaccines are for SARS-CoV-2 are protective against long COVID. They're not 100% protective. They're maybe at best 50% protective in these large observational studies. And both a prior infection and a vaccine can confer some immunity to someone, and both of those things seem to reduce long COVID to some degree, but incompletely, unfortunately.
Here's another good question that comes to this issue of correlation versus causation, really a chicken and egg problem. What came first? And it's regarding age-related conditions such as cardiovascular disorders. So did people develop COVID and long COVID because they had pre-existing conditions, or did COVID cause the condition? And I guess I'll start with that one. In the surveys, they ascertained whether or not people had a history of those conditions prior to COVID. So they tried to understand what were the predisposing conditions at the time of the COVID infection. But that said, we also know that many of those conditions can be a consequence of either an initial COVID or long COVID. So, for example, particularly heart failure, and some disorders such as people mentioned POTS before. Acronyms are always contextual, so that stands for postural orthostatic tachycardia syndrome. That's another common condition that really overlaps between the autonomic nervous system and the heart. So I think that it's not either or, it's and both. But what we really tried to look at in that study was people with pre-existing conditions. Did that predict onset of long COVID? And I think that the data did show that, and that it was independent of sex. And I think we know that people with the particular conditions I mentioned, like obesity, diabetes, cardiovascular disease, COPD, were more prone to develop COVID initially. And I think our study shows that they're also more likely to get long COVID. And Jason, I think that aligns with some of the data you showed about severity of initial illness too. It may map back to those people who were more ill to begin with. So it's an important question, and that's why the longitudinal studies are important try to figure out what came first and what's the consequence versus whether or not they were just simply true and unrelated, or just correlated and not causative. Okay, so there are also a lot of questions here that I think are going to come down to your opinions. All of you is seeing a lot of people who have long COVID. And the reason I say that is a lot of them are about, what advice would you give people with long COVID for managing, in sort of this data-free zone in many ways in terms of how to treat people. But what have been your observations? And then again, just being very clear, this is opinion-based because the clinical trials are ongoing to find out whether some of these interventions work or not. But people, because the question's been asked over and over, I thought I'd just throw it out for you to at least, give your impressions. There were a lot of questions about memory loss, fatigue, taste and smell. Anything that you've observed that you think might be helpful to people even at this point?
Yeah, I can start on that one, and if anyone else wants to jump in, feel free. I think in general, first of all, in the study, we don't really give out medical advice. We do need to kind of keep that line there, because the studies aren't really staffed, and the study coordinators and study teams are not a substitute for your own physician or provider's medical judgment. So all of these questions are really good, and there's lots of information out there now about some approaches to clinical management of long COVID, and I can try to summarize it briefly. So first of all, unfortunately, as of July 2025, we don't have any silver bullet pharmaceutical treatments that improve long COVID. So that's, I think, the first thing to start with, is that if you come to your doctor looking for that sort of cure, there really isn't something. And that said, there are a lot of conditions that can be diagnosed that do have treatments. So for instance, if you have dizziness and POTS, and or high heart rate when you're standing for too long, there are quite a lot of different treatments for POTS. We focus on staying hydrated, giving salt repletion, giving compression stockings, and other tactics. There are some medicines that that can be used there too. So diagnosing some of the other conditions, or kind of putting a medical diagnosis on some of the syndromes, I think can be very helpful in trying to start addressing the different long COVID phenotypes. And there's lots and lots of different phenotypes. I think it would take a whole hour to go through everything and talk about the medical recommendations, but just some of the things for smell and taste. That one came up a lot in the questions. This is a very common part of long COVID. There are no known treatments or cures for that, but I have seen some, ENT specialists doing some sort of exposure therapy. I'm not sure if that works or not. And I'm not sure how many providers are doing that. So I think right now what we have for that is kind of a watchful waiting approach. And it does seem to get better for some people, although there are some people who are affected very early in the pandemic. 5 years in now, we might not see some recovery in some people. There's a very interesting study coming out on smell and taste disturbance in long COVID from Recover. That's getting near to publication. I think we'll hopefully be able to share that at a future town hall. And it talks about association with neurologic dysfunction. So yeah, I mean, that's a brief start on some of that. I think one other thing that I'll maybe mention is the rehab. A lot of people had questions about rehab in the Q&A and in the pre-submitted questions. This is still an active area of investigation. I would say there's a lot of controversy over this as well. A lot of patients in the long COVID community feel that exercise, could be harmful. And there's this very well described idea about post-exertional malaise, meaning people have these quote unquote crashes after exercising that they get set back. So I think that this is a complicated area, and what I've heard as being the most kind of well-established approach is to try to personalize and individualize rehabilitation recommendations. So there are, rehab specialists, that have long COVID clinics. There are also some, kind of online resources popping up that are addressing this and trying to personalize an approach in a way that people can, continue to move and rehabilitate without getting too many crashes. And this has been, one of the long COVID clinical trials, and I think this will continue to be studied about the best approaches here.
Well,
I don't know
since
if
we're
anyone else
getting
has anything to add to that.
since we're getting to the last 5 minutes, maybe we could ask, especially our research coordinators, about the clinical trials that you're doing, because that's where we will begin to generate the evidence that Jason was talking about what actually works and what doesn't work. And I realize we don't have results, but maybe each of you, Lea, Ethan, and Julie, can talk about a study that you're excited about, that you'd like to make a pitch for to this audience, that they ought to pay attention to a certain area or a certain treatment. Julie, do you want to go first?
Not really, because we don't have anything right now. But we are hoping to open in the next couple of months a study with BioV under Dr. Goldman. But I can't. We don't have any active patients, so I think.
Can you tell us what BioV is testing and who's in the study or who will be recruited for the study?
Yeah, I can't, but I gotta pull it up. So maybe someone who has
Okay, all right. Sorry to put
working
you on the spot. Lea and Ethan, tell us what you're most excited about in terms of the studies you're working on.
So to be honest, Dr. Tuttle, we were working on several studies, but currently I'm still excited on the Recover Autonomic study, specifically because it incorporates that exercise portion in the study, which kind of inspired me to pursue my dissertation topic. As Dr. Goldman said, there's mixed literature on whether exercise is good or not for these individuals that are recovering. And there's a recent study that came out that a lot of these long COVID patients, they have a higher proportion of fast twitch fibers, which are basically highly fatigable fibers, and they can't exert themselves, or they'll be exhausted. And so what I'm doing in my dissertation is I want to see if resistance exercise at low intensities can help them to build their muscular fibers to more aerobic capacities so that they can eventually, walk longer distances and do some sort of aerobic movements. And that's what I'm kind of focusing individually. But as for future studies, I'm not too sure, but I'm excited to do them all.
Well, you know what? What's cool about that too is that the results of that will inform self-management, right? Like what exercise is a good fit for a certain type of patient. It gets to individualized care. It's something that people can do for themselves. It's not just a pill.
Absolutely.
And Lea, do you have something you'd like to pitch?
I think one of the exciting parts of the work we do is these studies are double blinded, and then there's the unblinding portion as well at the end, which I know Recover Auto will be happening later. It's going to take some time, but kind of also seeing how putting together kind of participant experiences with their symptoms, and also whether they were on placebo or not. But for auto, I'm interested to see the Avabradine arm, and IVIG as well has been incredibly popular. Ethan and I were really busy actually the past few months recruiting, and we still have study participants asking if they can join, but the enrollment has closed. But I think what's interesting about this is some some participants, quite a few, because part of our part is screening. So what arm do they fit best for? Or some participants will be randomized to either or. But the interesting part is a lot of participants have been on ivabradine to kind of already clinically as one of their medications to manage symptoms. So I'm curious from a long COVID perspective how this is going to be shown in like the results and literature. So both treatments will be very interesting to kind of see what comes out from it.
Yeah, and that
So there's hope. Yeah, so and pills as well as self-management with exercise. And Jason, over you to close us out. And if you guys want to make the pitch to BioV, do it in the last minute.
I want to be careful what we say just because we don't have all of our approvals in place, but it's an anti-inflammatory, and we're specifically looking at people with some cognitive impairment and fatigue. So that will be the cohort we're looking at. And I guess for folks interested, we will be putting up information once we're open on the Swedish website.
Yeah. So yeah, I think that there are a lot of exciting trials that are coming around. I recently, for a grant application, reviewed all of the trials for long COVID on clinicaltrials.gov, and we found 117. They're not all being performed, at the sites where these groups, on this call are located, unfortunately, but there are a lot of new trials coming around. And I would say, in general, the most exciting trials, I think, from my perspective, are the ones that are looking at antiviral approaches and anti-inflammatory approaches. And the bezisterim is one of the interventions. That's the BioV intervention that Julie was mentioning. That does cross the blood-brain barrier, and it works on inflammation. There's lots of other studies on inflammation that are under investigation now, including some pretty strong immunosuppressive drugs. And also IVIG, Ethan and Lea mentioned that. And then the antiviral approaches, Paxlovid has been studied. I saw a lot of questions about Paxlovid. So far, there's been 2 negative trials about Paxlovid, but the Recover Vital should announce results sometime soon, and that's a much bigger trial. It might give us a little glimpse at, seeing if there's any effect with longer durations or in different subgroups. Like people who have fatigue, for instance, compared to neurocognitive dysfunction. So we probably get a lot of information out of Recover Vital, even if it doesn't give that sort of silver bullet treatment, which we're a little bit thinking that maybe that's not just Paxlovid, but combining antivirals and anti-inflammatories. So I think there is a lot of exciting interventional research on the horizon, and we'll try to keep you informed of that, and definitely let you know when there's opportunities for enrollment in interventional studies. So I know we're a minute or two over, but Kathy, anything else to say to sort of wrap us up? Or
no, just thank you to all the participants who joined us tonight for being engaged and sending in your questions, and I think all of you too as well. I think it's a hopeful message. We're starting to unravel the knot, and we're moving beyond purely correlation studies to clinical trials where we can test causation and find out what works. And I think the one thing that I just wrap up with, Jason, that I think you said was really important when you were talking about biomarkers, it's also how people feel and function. And in fact, in clinical trials, the US FDA and other regulatory agencies recognize that feel and function, again, in addition to survival outcomes, is something good enough to say that a drug is efficacious for a condition. So we don't underestimate the feel and function part of this, and that'll be an important part of the trials too, is how people are feeling and how well they're functioning. Besides all of our organ-specific interests and such like that. So I think it's a hopeful time. I think we are making progress. And so stay tuned, and thank you all for joining us and being so involved.